I'm from Amrita Institute, Cochin. About 4 years back, our institute got the Da Vinci robot, which is meant for the gastro, uro, and gynae people, and the ROSA robot for neurosurgery. So that was the time when the hospital management asked us whether you guys need any robot. So we were kind of taken back, and the only robot which came to our mind was Mako. So that's how we landed up getting this robot in our institute. We know that this Mako robot has been there since 2006. It has evolved. The current is the third generation Mako. And a couple of years back, they kind of launched the total knee replacement also along with that. But in this talk, I'll be sticking with the Unicompartmental knee replacement experience, what we have in our institute and how we go about it and the way I understand how it works. So with this particular machine, we can do a medial and lateral uni. You can do a patellofemoral replacement and also a bicompartmental knee replacement if needed. It follows a standard workflow where you need a CT scan for this robot to work. You segment it, you take landmarks, and then you pre-plan both in the femur and tibia. So when we take a CT scan, you have to take right from the hip, knee, and the ankle. More cuts are taken towards in the knee. And the MPS, that's the Mako product specialist person, reconstructs in these CT images into 3D models. And CT landmarks are identified, and you sit along with your MPS personnel and you try to register the bone. So this is the time, even before we start the surgery, we sit with the person and we do the exact sizing of the implant, what is needed, the positioning. And also to some extent you can look at the balancing of the gap and also how the femoral and the tibial component tracks against each other. All these can be further fine-tuned when you start your surgery and intraoperatively. So you can sit for some time and pre-plan it, which is extremely nice in this instrument. As far as the tibial size is concerned, you can change the position of these implants depending upon the rotation, whether you want to change it varus valgus, the slope, everything can be adjusted to some extent. And also on the femur, the exact size, because the CT scan gives you a lot of information and you can match the size very well with the data what you have, and you can change the rotations according to what you need. Once you start your surgery, it is a standard medial parapatellar approach. You need array placement just like in navigation, because that's where the robot communicates with the bone and what you register, and that's the live feedback what you have during the surgery after the bone registration. You can also do some pose capture at different angles, starting from 10 degrees, 30, 60, 90, and 120 degrees. This gives you some idea about the gap balance and also the tracking of the femoral component on the tibia. Remember, all these are done even before we started doing the bone cuts. So here you get a nice graph where you can see how much is the laxity or the gap between the femur and the tibia, and how much you want to fine-tune your implants. And also it gives an idea of how the femoral component is to track on the tibial component. And as usual, depending upon whether the extension gap or the flexion gap, which is it tight or loose, and then you can adjust. That is the whole picture out there where you can do a lot of adjustments on these components. And another important feature with this instrument is that the robot is that you can also map the cartilage where the anterior end of the femoral component. You don't want it to be too proud. You can recess it or keep it flush so that the patellofemoral tracking will be good and for a smooth patellar transition in that area. So that also helps you to a large extent. You can see the tracking of the femoral component on the tibia. The red dots, what you see there are the tibial points, and the black line is the point where the femur touches the tibia. So all these can be looked into before even if you start your cut. So once you get your final review, you are happy with it, you go ahead and start registering your robotic arm. And it is a burr, it is a saline cooled burr, I think it's around 5 or 6 mm, and you use that burr to prepare your bone. And you can take exactly the amount of bone what has to be taken. And it has got a haptic feedback that even if you err and if you want to take excess bone, the robotic arm stops you there and guides you exactly where you want to take. In the same in the same way, you can burr the tibial side also. So it's very precise, and you know what exactly you are taking. And once you get your trial implants, you can put them and again do the final kinematic analysis and see how your gap is. If you feel the gap is too loose, you can increase your poly thickness and get the gap right. And then you do the final cementing, and then again you can do a kinematic analysis. So when you take the X-rays postoperatively, we were kind of surprised in our early cases to see how exactly the implant fits the bone and how accurate the sizes are. So these are our early experience. We have been doing this since last year, and we did a small study with the initial 22 cases of robotic arm versus our previous jig-based 12 Oxford knees. And we just looked at the tibial component, how the varus valgus and the posterior slope is. And we could see that the robotic arm UKRs, the implants were much better position, which was kind of statistically significant, even though the numbers were pretty low. And you should also realize these were very much in the early learning phase of the surgeon as far as the robotic surgery is concerned, but the accuracy rate was pretty impressive. And we also did a couple of bicompartmental, only 2 of them. Thank you very much.